Okay,
There we are. We should be live.
Thank you, Emma. So welcome everybody to September's CCG governing body held in public, which we are live streaming as we have done over the past few months. So want to welcome everybody who's joining us and welcome everybody who may be watching us. And I'd just like to welcome some additional and new members to our governing body this month. So welcome to Helen Lenthal, who's joined us as the locality manager for Hallam South, and welcome to Dominic Carroll, who is joining us as the locality manager for West. I also just want to welcome Danny Hides, who's on the call today, who's going to be presenting some of the papers. So welcome everybody. Dominic and Helen, I'm assuming you won't know everybody, so what we'll do is if we could just do a quick introduction of who we are and what our roles are, that will probably be helpful for our new members, but also for members of the public. So I'm Terry Hudson, I'm a GP in Sheffield and chair of the CCG, and I'll hand over to Leslie Smith, please.
Good afternoon, both. Leslie Smith, accountable officer at CCG.
Okay, Karen Shaw, please.
Hi Dominic, so I'm Corporate Secretariat and PA to the Director of Finance.
And Sandy.
Brooklyn, Director of Commission Development.
And Carol.
Carol Henderson, Corporate Governance Manager.
Mark, please. So, Mark, you're on mute.
Mark Gamsu, a lay member on the CCG.
Okay, Alan, please.
Alan Windle, Chief Nurse, CCG.
Thank you. Anthea.
I'm Anthea Morris. I'm the lay member for Audit and Governance at CCG.
Thank you. Lisa.
I'm Lisa Phillip. I'm one of the GPs on governing body.
Thank you. Jackie.
Hi, I'm Jackie Mills. I'm Director of Finance and Corporate Services.
Thank you. Marion.
Hello, I'm Marion. I'm a GP. Hello, Dominic. Hello, Helen. Nice to have you.
Judy Robinson, please.
Hello, I'm the chair of Sheffield Health Watch, which is the watchdog for health and social care in the city.
Thank you. Nikki.
Hi, Nikki Bates, GP on the governing body. Hi.
Thank you. David.
Hi, David Warwicker, governing body GP representing North Sheffield.
Thank you. Emma.
Hello, I'm Emma Shepherd and I'm Communications Assistant at Sheffield CCG.
Thank you. Kath.
Hi, Kath Tilney, Associate Director of Corporate Services.
Thanks. Danny, please. So Danny's audio wasn't working there, even though you unmuted yourself. So Danny Hides is our Deputy Director for Quality in the CCG. And hopefully we'll get the audio working in due course. Lee, please.
Hi, I'm Lee Salisbury. Helen and Dominic and I have already met at CLG, so we're delighted to have you on board. And I'm a GP on governing body.
Thank you. Judy, please.
Hi, I'm Judy Thorley. I'm lay member on the CCG with the CCG.
Chris.
Chris Neal, lay member on the governing body.
And Paul, please.
Paul White, Joint Locality Manager for Central Locality. I think we've already met.
Okay, thank you. Okay, so that's been a helpful attendance list. I'm going to just run through the apologies for absence today. So we've heard apologies from Zach McMurray, Brian Hughes, with apologies from Lucy Ettridge, apologies from Greg Fell, and apologies from John McElwraith. Otherwise, everybody is here as anticipated, and we're good to go with our meeting. So before we proceed, has anybody any declaration of interest they wish to make in any of the items on today's agenda? No, thank you. So I'll move us on to item 5, which is paper A in the noting pack, which is the unadopted minutes of the July governing body in public. I will take those page by page, and if there are any corrections that need to be made, if you could indicate those as we work through. So pages 1 and 2. 3 and 4, 5 and 6, 7 and 8, 9 and 10, 11 and 12. Sandy, please.
Yes, thank you, Chair. I was going to pick this up as matters arising as well. It's just to change the action for feedback to go back to the Joint Committee of CCGs. This is for pages 11 and 12 rather than the Joint Co-Commissioning Committee.
Thank you. So we'll update the minutes that the feedback regarding the Commissioning for Outcomes framework, the feedback was to go to the Joint Committee of CCGs across South Yorkshire and Bassetlaw and not into the Joint Committee, which we have with Sheffield City Council. And another point of accuracy that you've brought up with me, Sandy, is the action was for Brian Hughes and myself to feed that back as members of that committee. So if we can amend that and also make sure that we amend that on the matters arising as we go through. Thank you. So pages 13 and 14, 15 and 16, and pages 17 and 18. Okay, thank you. So subject to the amendment and suggestion Sandy's just made, we'll accept the July minutes as an accurate record of our meeting. So I'll now move us on to item 6, paper B in the noting pack, which is matters arising. So item 122.19 regarding workforce, we had an update at the last governing body from Brian Hughes. The item remains open, and in Brian's absence today, we don't have any further update on that. So we'll keep item 122.19 open. Item 36/21, a meeting between the chief nurse to discuss disability and additional needs. Do we have any update on that either from Danny, Alan or Judy, please?
There isn't an update from me, Chair, on that one.
Okay, so we'll keep that item open, please. Item 50/21. Jackie, do you have an update on the item now? Note that the matters arising table suggests that that's scheduled for the October meeting or December meeting at the latest. Is there any change on that position?
No, we haven't confirmed the agenda yet, but we will confirm. I think probably more likely December, given some of the work that's ongoing at the moment in terms of refreshing the Section 75 agreement for the Better Care Fund.
Thank you, Jackie. Item 64/21 is now closed. Item 71/21 is closed. Item 80/21 has been closed. We've got action 82/21 just regarding the Commissioning for Outcomes policy. As we've just highlighted in the minutes, the action was for Brian Hughes and myself to feed that back to the Joint Commissioning Committee, which we have done. So if we can close that item off, that would be helpful. Thank you. Item 82/21 was regarding a discussion that Dr. Amir Afzal brought up just regarding GP input into the IFR panels and how that's communicated back to patients. Danny, are you able to give us an update on that item, please?
Can you hear me?
We can now, thank you.
Right, okay, I've had to sit it quite close. It's yeah, so I can confirm, spoke to the manager in the IFR team. They do copy patients into all communications. They do believe that as a result of COVID and some home working, there has been a slight gap in some of that. However, they've put a recovery plan in place, and they now have somebody coming back into the building that's able to send out paper communication, so that should come back on track. If there's any problems, we're happy for it to be escalated back to the IFR team.
Thank you, Danny. And we'll pass that on. I know Amir has joined us, so hopefully that will give the assurance to the question Amir had made previously. Item 8321 was to put forward an agenda item for the BCF annual report. I note that this was something to be added to the forward planner. Sandy, do we have any further update on that at this stage?
No, that can be recommended for closure, Chair, because the responses were fed into the operational plan and is part of the forward agenda going into the future for governing bodies. So it's one of the standing items, so that can be recommended for closure.
Thank you, Sandy. Item 8421 is now recommended for closure. 8521 also recommended for closure. And then the final item we have is item 8621, just regarding our send update. And there was an action there for Sapphire to pick up a discussion with Leslie and Lee. So Leslie or Lee, have you had any further discussions on that one? Is there anything that we need to update for the matters arising?
I've not had a further discussion with Sapphire.
And I haven't had a further discussion with Lee or with Sapphire, so I think it's something for us to pick up.
Perfect. Okay, fantastic. So I'm now going to move us on to item 7, which is patient story. And I believe, Danny, you're going to introduce this month's patient story for us. So over to you, please. Thank you.
For some context, for the past 2 years, Sheffield has been one of 12 early adopter sites testing new models of care around primary and community mental health support and treatment. Today's patient story is about Tammy, who is a service user with borderline personality disorder and anxiety, who was assessed and went through one of the early adopter sites. Tammy is going to share her experience of how mental health support in Sheffield used to feel and how she feels now, and how things have improved for her since she was introduced to her primary and community mental health worker. Can I stress that Tammy's story contains a reference to suicidal thoughts, which may cause distress to some people. I'm conscious that this, and we're in a public forum. So if you are uncomfortable, please turn off your volume if you feel you may be affected by Tammy's story, and we'll let you know when to turn your volume back on. Thank you.
I think they were really poor, actually. No, I do know they were really poor. I think I started attending Eastglade when I was 18 and getting onto trying to get help for my personality disorders. It was difficult, very difficult, and there was no support. Basically, the last 20 years I moved up. In that time, there was no support, and unfortunately through the lack of support I did take an overdose and tried to end my life. Recently I got more support, and my doctor mentioned about Chris, and would I like to get him to ring me. So when Chris was going to ring me, I was in a bad way again. I was thinking suicidal, and I was really at a very low point. And then I got introduced to Chris, and we started working with him on my mental health, and it's changed my life. I've gone from wanting to jump off a bridge to get out of bed in the morning. And I think it's so important that this support is here. I thought it was a new thing. I mean, it's been going on for a year, and I do think it's vital that people have the same access to this service that I've had, because I think it'll make a real big difference, because now, especially like way things are with COVID, there's less support for mental health, and there's less appointments, less funding, but the difference I found is having access to your service. It's changed and it's supported me immensely. And I'm really grateful for that. And I feel like I'm getting my life back on track.
Just to add a couple more points, if I can, Chair, just to say that it's obviously really emotive, but actually that it's warming to hear that Tammy's got a more positive outlook, and the benefits of integrating primary and secondary health services is having a real impact on the individual. So I just wanted to add that. Thank you.
Okay, thank you, Danny. Are there any comments or reflections from governing body on Tammy's story? So David, please.
I want to be careful how I say this, because this is a good story and this is a win. I think that there are a lot of there's still a lot to do, a lot to do about mental health and integration between primary and secondary care, mental health, access for patients to services like this. But I don't want to sound like I'm whinging too much. But this is great to hear that Tammy has had, having had previously real like negative experiences, has got a real win out of this, and that's great. But I hesitate to pat us on the back too much, because I don't want us to lose that drive to really improve mental health services for our patients, because there's a lot to do.
Thank you, David. Any further comments or reflections? Okay, Danny, could you drop a note to Tammy just to thank her for sharing her story with governing body? And I know that she's also shared her story as part of other initiatives that we've been involved in. So if you could pass governing body thanks on, that would be very grateful. Thank you. Right, so I'm now going to take us on to part 2 of the agenda, which is papers for approval. So this is item 8 on the agenda, is paper C in the document pack, and it's the item is the Emergency Preparedness, Resilience and Responsive Standards Statement of Compliance. And in Brian's absence this afternoon, Jackie's going to take that paper. So over to you, Jackie.
Thank you, Terry. I will do my best to cover this off. So governing body members will be familiar with the annual process that we need to take to assure ourselves that as an organisation we've got proper arrangements in place to be able to effectively respond to major critical business continuity incidents while still being able to maintain services to patients. We have formal arrangements in place around our emergency preparedness, resilience and response, EPRR arrangements. You will note that we have properly tested those over the last 18 months as we've had ongoing requirements to respond to the COVID pandemic incident. But this is a more formal process just to go through the standards to complete a checklist and to recommend to governing body that in light of that self-assessment that we've undertaken, we are recommending that we put a statement of compliance forward as being fully compliant. Whilst the requirements for us to test these out are less onerous than they have been in the past, it is important that we make sure that the assurance that we can internally provide ourselves is that we've got adequate arrangements in place, and we are confident that we can do that. The self-assessment is included as an appendix. I know it's quite small, so hopefully everyone will have been able to review that. But that's all I wanted to say in terms of introduction to the paper. But I am happy alongside colleagues elsewhere that might be able to respond to any questions that you might have.
Thank you, Jackie. So any questions or reflections on this paper? Chris Neal, please.
Thanks, Jackie. I just wanted, I know that they did a subset of assessing the standards, didn't they, because of COVID, but just a reflection really that I think because of the real life pandemic, a lot of these issues will have been strengthened and reviewed as we've gone through the COVID process. And I know that we've got, strong information about that will have a good impact on this. And just for note, there's one about requirement of the local authority and the CCG in terms of mutual aid when people are in this situation. And that is the standard, and we pass that standard, and we've got lots of evidence of that. But just to also say what a difference the community's made in that arena as well with COVID. And it's not a criticism of this, but because this is checking that we comply with those standards, but we had much more in terms of support for people in managing the situation we were in through all sorts of different areas, but particularly wanted to reflect on the community mutual aid that came together, particularly in partnership with the voluntary sector. So thanks for doing that. It's Sue and Brian have done this report, but so much learning we've had that we've put in place.
Thank you, Chris. And I think it's sort of an addition to this paper. I mean, the paper is our compliance statement, but I think you correctly highlight the significant amount of learning that as an organisation and as a wider system we've had over the past 18 months, particularly related to our emergency response and the importance of networking with other people to really create that community resilience. So thank you for highlighting that, Chris. Anthea, please.
Thank you. I echo what Chris has said, and I think our understanding of emergencies has changed over the last 18 months. I remember last year we discussed that we were prepared for a train crash, but we weren't prepared for an ongoing pandemic. And I think that's really reassuring that we've incorporated that in our plan. I'm also delighted that we're fully compliant pretty much all the way down, but I do have a question. Do we know how our partners are doing and their compliance? Because we're only as strong as the weakest link in the chain. And for the people of Sheffield, and as we think more about partnership working, do we need to offer any support to anyone who perhaps isn't as reporting as fully compliant as us?
Yeah, I'm not sure I can answer your question today, Anthea. I think as a set of partners, we're all at the same point in terms of doing this self-assessment, but I think it's something that we can confirm and feed back into governing body.
Yeah, I'm not trying to create extra work, but I think I think it would be useful as we go forward to understand where everyone is in our brave new world in 6 months' time.
Yeah, I'm happy to take that as an action.
Thank you, Anthea. I think it's a really important question, and just reflecting that our EPR arrangements are a part of kind of that partnership arrangement in Sheffield, but also forms part of a regional cell. And it may be the case that we ask for some information of that to come back to governing body in due course. So I will try and pick that up with some colleagues at the ICS and NHS England, and also with our Director of Public Health, Greg Fell, who leads in that space as well. And hopefully we'll be able to provide you with an update. Okay, any further comments at all? Nope. Okay, so are we happy to approve that paper and publish our standard of compliance? Okay, thank you. So now move us on to item 9. This is paper D in the noting pack. So this is a proposal to put in place additional arrangements for the transition to integrated care boards as part of the joint committee of CCGs with our fellow CCGs in South Yorkshire and Bassetlaw. Again, in Brian's absence this afternoon, Jackie is going to present this paper for us.
Thank you, Terry. Yeah, so as the paper sets out, this is a proposal to manage preparations for the establishment of the statutory integrated care system, including arrangements to set out the establishment of an integrated care board and the plans to operate in shadow, for that ICB integrated care board to operate in shadow form from Q4 of 2021-22. both the statutory functions of current CCGs as well as some functions from NHS England will transfer to the Integrated Care Board, alongside some non-statutory functions of ICSs, including strategic planning, transformation and oversight. And the proposal is that the 5 CCGs and the ICS wish to come together in to ensure a smooth transition to the Integrated Care Board from April. It's been decided that the most practical way of doing this is for the Joint Committee of CCGs that we already have in place to coordinate the preparatory steps for that transition. The proposal in the paper outlines that it's proposed that the remit of the Joint Committee be expanded to take into the scope of delegation this transition work, and that attendees from the current ICS, or as we move to establishing shadow ICB designate posts, that they attend the Joint Committee of CCGs, and that we establish a formal subcommittee of the Joint Committee of CCGs, which would be the Change and Transition Board. The paper also notes about, we've had confirmation that NHS Bassett Law will be moving from the current South Yorkshire and Bassett Law system into Nottingham and Nottinghamshire ICS from 1st of April. But up to the end of March, Bassett Law remains within the current South Yorkshire and Bassett Law system. So it's important that any transition arrangements take into account that change in the way in which Bassett Law CCG will point. While some of the discussions at Joint Committee of CCGs may not be relevant for Bassett Law, the proposals allow for Bassett Law to be involved in all relevant discussions, but that other business can carry on without Bassett Law being involved. So specifically, the proposal is that the delegation to the Joint Committee of CCGs be expanded to take into their role the remit of transition, and that we add we amend the manual of agreement and terms of reference for that committee to include a schedule 3 that sets out all these arrangements, including the establishment of the Change and Transition Board as a formal subcommittee of the Joint Committee of CCGs. So it's all a bit technical, but it just allows us to work together in a consistent and integrated way across the 5 CCGs and the ICS team, and allows us to undertake the requirements of safe transition of CCG functions into the new Integrated Care Board. So I'm happy to take any questions.
Thank you, Jackie. Any questions from governing body at all? Okay, so I think, Judy, are you wishing to ask a question?
Yes, please. Jackie, you may not be able to answer this, but and I know that this paper is largely a technical one, but in the very last Appendix 5, which talks about the duty for public involvement, I just want to ask about the citizens panel, which is mentioned. I have completely failed to track this down, and can somebody tell me who they are, where they are, and any names? Because it seems to me that out there is a lot of suspicion about the ICS move, and I think the more we can do to share the information, make it clear what it is, and involve people, the less that suspicion will be. But I don't actually see that sort of communication at the moment. Can you help?
I'm not sure I can. I don't know if Leslie can, but I have seen some feedback from that panel through the Joint Committee of CCGs today, and I think there is reference to it on the ICS website. But Leslie, I don't know if you can.
Yeah, I think if it helps, the ICS did quite a wide recruitment to its citizens panel in the last couple of years. So what might be helpful, Judy, is if we take away from this meeting getting an update from Helen in terms of the size and composition of the panel as it currently stands, and how they're engaged, and share that with you, if that would help.
Yes, it would. Thank you.
Thank you, Judy. Any further questions or reflections? Okay, so Jackie, if we can feedback, and I will also feedback as the chair of the joint committee, feedback to Lisa Kell, who's been coordinating this work for us, that we have approved the amendment to the manual agreement and terms of reference to allow us to undertake that technical exercise of transfer of our functions from CCGs and prepare for the statutory ICBs pending legislation when they are established. Okay, thank you. Item 10 now on the agenda, which is the procurement strategy and plan. And that's paper E in the document pack, and back over to you, Jackie.
Yeah. So this is actually a paper that I prepared, so I'm a bit more comfortable presenting this one. So this is our procurement strategy and plan. CCG is required as part of the Health and Social Care Act 2012 to publish an annual procurement plan. So apologies, it is later than we would normally do, obviously in terms of capacity constraints as we continue to respond to the pandemic. It's been delayed. It's also good practice for us to review our procurement strategy at least once a year, so I will just take that element first. We are proposing no changes to the CCG's current procurement strategy. It remains fit for purpose for the current financial year, given the changes that we've made previously to include the arrangements for the UK's exit from the European Union, as well as other changes in terms of our tendering requirements. However, as the paper notes, the new draft health and care bill proposes removal of barriers and arrangements to promote collaboration between NHS organisations, and that includes proposals to change the procurement and competition requirements of the 2012 Act. So there is work to be done to draft a revised procurement strategy for 22-23 onwards for the newly established Integrated Care Board, and that work will be undertaken as part of the change and transition work. So I just wanted to note that. The paper also summarises the procurement work that was undertaken in 2020-21, noting that that was severely impacted by the pandemic, both in terms of the fact that our procurement team took a lead role in sourcing and supporting the distribution of PPE to particularly primary care, as well as provider wider system. But also because a number of our normal commissioning teams were engaged on responding to the pandemic as well. So there was less procurement work than we would normally do in a year. And then finally, the report sets out the procurement plan for 21-22, which is based on the commissioning intentions previously approved by the governing body. As this report's been slightly delayed, it notes that some of that work is actually already complete. But if governing body are supportive in approving this paper, it will be published on our website. I think they were the main things I just wanted to draw out from the paper.
Thank you, Jackie. So noting the actions and recommendations for governing body here, we've been asked to consider and approve the paper and to note the approach to the future amendments, but keeping in mind that legislation is yet to pass and be completed, and there's a degree of being nimble here as we develop this policy in light of a legislative proposal. So question from Nikki Bates, please.
Yes, thank you. I was wondering, Jackie, whether Sheffield Children's Hospital Foundation Trust is part of the progressive procurement collaboration. It's not specifically mentioned in the list on page 4. There's the CCG, Universities College, City Council, and the Health and Social Care Trust, but not Sheffield Children's Hospital. And I wondered if they are actually part of this or not.
I'm sorry, Nikki, I don't know the answer to that, but I can clarify.
Okay, if they're not, I could perhaps bring that up at the Children's Governors meeting.
Yeah, so I'll separately drop you an email to confirm.
Thank you.
Thank you. Any further questions for Jackie? No. Okay. So thank you, Jackie. And we'll arrange for that policy to be, or rather that plan to be published on our website. So thank you. So take us now on to part 3 of the agenda, which is papers for consideration.
Chair,
And,
sorry.
Mark, yes. And Mark has frozen on us there. So hopefully we'll be able to come back to Mark's question a little bit later, Jackie. We may have to just skip back to that agenda item to answer that question whilst the internet issue is resolved. But I will now bring us on then to item 11, paper F, which is the month 4 financial report. And once again, back over to you, Jackie. You'll be glad of a rest after this item.
Yeah, thank you, Terry. Yeah, so this is the financial report up to the end of month 4, and you will recall that as governing body we have approved a 6-month financial plan in light of the current financial arrangements confirmed by NHS England. So we're 2/3 of the way through that financial period. We are still managing a range of financial risks. The most worrying at the moment is the position in relation to continuing healthcare, and we are seeing significant pressures come through in terms of both adult and children's continuing healthcare packages. We should also note that the local authority are experiencing similar pressures in terms of their social care pressures, and we are working together to both understand the causes of that pressure, but also to look at how we can jointly respond to that. So conversations are ongoing with our council colleagues in regard to that. We have had a significant number of very complex packages that we are managing, and I do need to note that Danny's involvement in this is particularly valuable because she personally manages and reviews a number of those. So we have got significant pressures coming through there. The other area I just wanted to note is the hospital discharge funding. This is funding that we can draw down from a national pot. At the moment, the arrangements are only confirmed up to the end of September, and we are awaiting information about what may continue after September, but there are strong indications that that funding will significantly reduce. That funding is supporting a number of our packages at the moment, so that will bring with it significant financial risk in the second half of the year. One piece of good news is that each system was allocated an indicative amount to draw a maximum they could draw down from the hospital discharge funding. The amount allocated to South Yorkshire and Bassetlaw was very low. If you compare it to a national share, it was very low. We have been involved with national and regional colleagues to argue for an increase in that indicative limit for South Yorkshire and Bassetlaw. And whilst we still await formal confirmation, there is positive noises that that indicative limit will be increased for us. And that manages some of the financial risk because we were forecasting to spend in excess of that limit across the 5 CCGs within South Yorkshire. The final bit, and probably is a bit more challenging for us to manage, in the second half of the year, we are still waiting confirmation of the financial arrangements and the financial allocation. There are strong indications that the funding available in the second half of the year will be significantly lower than we've had in the first, and the pressures that we are forecasting in terms of ongoing expenditure for the second half of the year are challenging. We've done some initial estimates in support of some work that the ICS have been doing with the regional colleagues, and that indicates that for the second half of the year we will have a fairly sizable financial deficit to manage. I will be bringing proposals back to governing body once we're clearer of the arrangements that will be in place. We are expecting in probably, well, hopefully a couple of weeks, but timescales often slip, that we'll have some initial confirmation of those arrangements. So I think given that the next public governing body is not till November, we will probably provide some update to the development session in October Sandy and myself will be doing some work in terms of planning for the second half of the year. And then just finally, just thinking about 22-23 onwards, obviously it will be the ICB that will be producing a plan for that, but that will be based on the plans of the 4 South Yorkshire CCGs. So we are looking forward to in terms of our current commitments and working as a group of CCG CFOs to be able to pull together a single commissioning financial plan. But still recognising there's a significant level of uncertainty in terms of resourcing and financial arrangements for next year as well. I think they were the key points I just wanted to draw out from the report. It's just really challenging in terms of lack of certainty, plus some known pressures that we will need to manage.
Thank you, Jackie. And just a quick reflection there. I almost play back the last year or so with our financial reports, and uncertainty has been one of those key themes. So probably just a thank you to you and the team for how you manage that uncertainty and try and gain as much clarity as you can in our plans. I think it does make our life as a governing body easier, although it probably doesn't make the finance team's life any easier. So just to acknowledge that. Okay, take a question from Lee, please.
Yes, thank you. And as ever, Jackie, thank you. I echo everything that Terry says, that all that you do, it is an amazing job that you're doing in unprecedented times. I've got 2 questions. My first one might seem a bit flippant, but I promise you it isn't. And it sort of informs my next question. So my first question is, do we know what the thinking is behind the decision to reduce funding in the second half of the year, which includes winter?
I think there are 2 things happening in terms of that. When the initial planning indications were set out, there was an expectation that COVID would have reduced, that we'd be coming out of the pandemic, and so some of the arrangements we put in place, we should be planning to take those out. You'll be aware there's a very live conversation about the primary care capacity at the moment, and pressures in primary care, including ongoing requirements to provide hot hubs. So there's a real disconnect between expectations of reducing response and the reality on the ground. And the second thinking was around we should be able to refocus our attentions on delivering efficiency savings that NHS England Treasury acknowledged we'd kind of not been able to focus on during last year. So reducing expenditure on COVID and an expectation of focusing on efficiency has driven a lot of the messages. NHS England have been in negotiations for a considerable amount of time with Treasury about agreeing a funding settlement for the second half of the year. And you'll have seen in the national press this morning, there's ongoing lobbying that's still happening around that, both in terms of the second half of the year and resources for next year as the comprehensive spending review becomes imminent. So I think there's just lots of expectations, but on the ground, a feeling that those expectations are very challenging.
Yeah. So my second question is, I was just wondering, on the basis of that, whether there had been a lot of funding that's come in with an expectation that the system was dealing with a lot of COVID. And I wondered how, and this isn't a primary care versus secondary care, this is a sort of system question. I'm wondering how much of that money was sort of front loading secondary care to deal with a lot of the COVID stuff, which maybe wasn't as bad as we thought earlier on in the year. And so going back to your what you were saying about actually the pressures on continuing care and care packages and the conversations that we're having with the local authority, I wondered whether the STH was part of those conversations as well, because we are a system, and we've all got to be able to talk together. And having been in a meeting with Kirsten the other day when she was talking about the number of people who are stuck in hospital because they can't be transferred out because of the pressures on social care, it is a system. and presumably the answer in financially straitened times has got to come from us all working together. So I did wonder, how much of a conversation is happening at ACP level about this. I'm assuming there's lots, but it would just be nice to have your reassurance.
Yeah, I think probably there are some, probably not enough in terms of everyone. I think the pressure of work means everyone's focusing on their own problems and trying to firefight that, and there probably is a need to having more understanding of the pressures as a system as a whole. I think that the planning for the second half of the year will inevitably play those pressures out in clearer focus. So I think once we've got some further guidance, that those really important conversations will come to a quick clarity. I think the COVID spending in the acute sector, there is quite a lot of that, but again, I think we need to test where the priorities are for that continued investment, and some of the hard decisions we are going to have to make as a system in terms of which things get funded and which don't. Excuse me. So I anticipate that we'll be having more dialogue over the next few weeks in terms of being able to clarify that.
Okay, thank you.
Thank you, Lee. Any further questions or considerations of this paper? Nope. Okay, thank you, Jackie. And thanks, Lee, for that quite pertinent, important question. I think there's more work and more discussion for us to have with system partners, and certainly I'll feed that back into the conversations that I'm having in the ACP space. So that will be helpful feedback. So Jackie, thank you. I think time for you to have a rest now and get a glass of water. Over to item 12 now. This is paper G in the paper pack, and it's the month 4 performance and delivery report. And I'm going to hand over to Kath Tilney, please.
Thank you, Terry. I'm glad to give Jackie a rest. So there's just a couple of points that I wanted to highlight from this paper, and they link to the planned services around local acute hospitals, looking at the urgent care measures, and then around the staff temperature check. So just really pointing out that although there's obviously the pressures that we've talked about, things are moving in the right direction in most of the planned care services measures. At the last governing body meeting in July, I reported that there'd started to be a turnaround of 52-week waits of people waiting for planned appointments or treatment. So in April, that started to go in the right direction, and it's continued to do so. So in June, there were 810 people waiting over 52 weeks, and that reduced from the lowest point, which was 1,057 in April. So it's continued to go in the right direction, but obviously we don't want any 52-week waits, and that's what we're aiming for by the end of March. And that was the position we were prior to the pandemic. But there are a number of risks associated with this plan, and that's sort of building on what Jackie was saying earlier. There's continued impact and pressures of COVID, and the plans are in place to try and mitigate those risks, and those that are most clinically urgent are being managed on the waiting list. It's worth noting, and I generally notice this, that Sheffield and South Yorkshire acute providers are in a better position compared to other similar providers in the surrounding area. So, for example, at Sheffield Teaching Hospital, we've got just over 1,000 patients that are waiting over 52 weeks. In Hull, there's nearly 11,000 at the University Hospital of Derby, and Burton there's 8,500. So it really is significantly much better in Sheffield compared to other areas. So it's worth just taking that into account. As far as urgent care is concerned, there has been a recent decline in quite a number of measures linked to urgent care. You can see that step change in the report. included in waits at A&E, people waiting over 4 hours, increased delays, number of people where there's delays in handover from ambulance within A&E, and also response to calls. So these are all signs, and I'm sure there's many other measures that aren't in this report, but these are the ones that we need to include in the report. But there are lots of measures where we're seeing the pressure that there are in the system. Within the report, it describes some of the reasons behind that and what's being done to try and mitigate against that position. The final point I wanted to raise was linked to the June and July temperature check results. So temperature checks, but what we do with our staff on a monthly basis, we ask them how they're doing, what they think's working well, and what areas they may have concerns. So there's a lot that's really positive comes out of this survey that we do, and there's many staff that are still telling us that they're thriving with the new flexible arrangements and working the way we do. However, there is, for some staff, there's a small increase in those staff that reporting that they're struggling with their mental health, and that we saw that happen in the last couple of months. That's something that we've been working on with staff for a long time now, and I report to you on a regular basis. And understanding what's underneath all of that, it isn't all related to work, but for some people work isn't helping. So they're telling us that workload and concerns about returning to the office sit underneath some of those. Some people, we've done a lot around signposting to support and involving staff in the new ways of working. But it feels like we wanted to just stand back from that and look at what we're doing, if there's anything else that we can do. We had a session not too long ago with all the deputy directors that oversee all the staff that are in the organisation, and we were lucky that Terry could join us for that as well, which was great. And we just stood back from it all, had a good session and thought about some other ideas as well. That's joined up with the staff wellbeing group, and we're thinking about introducing a wellbeing one-to-one process and having a bit of a session with all managers that are keen to be involved around supporting staff with their wellbeing. So there's probably lots of other things as well, and we'll be sharing those with staff too. I think those are the main points to raise, so happy to take any comments or questions.
Thank you, Kath. So first question from Mark, please.
Right, let's see if I get thrown out. Kath, I think I ask you questions about this every time, and which goes back to the assessment of data quality linked to protected group measures. And I the more I look at this, the more I get worried. For example, the teaching hospital has not got, according to the code, information available on the ethnicity of people on the inpatient waiting list, according to the table. For reasons I really don't understand, the Care Trust can't tell us about sexual orientation and gender reassignment. No one can tell us anything about asylum seekers and homelessness. Even the teaching hospital, where presumably people turn up and use their services on an urgent basis. So what seems to come across at the moment, which I suppose affirms your work, or the work that's going on here, is that the NHS really struggles to look outside of its doors to the wider communities and the wider issues that people are facing, and indeed really struggles to have a grip on people who are experiencing inequality. So I know I raise questions about this every time, Kath, but I just wonder whether we should be starting to produce some sort of analysis that maybe, if what I've said is vaguely correct, that actually spells this out.
I think there's an
element. Did you hear any of that?
I did, yes.
Right.
Yes, so I think there's an element of what you're saying is correct, but there is a difference between the information that we receive as commissioners and the information held by the providers. So what we're doing here is looking at the national data sets that providers are required to give to us, and they aren't necessarily required to give us all those measures. So we're partly doing a bit of a a download of what we do have and what they are meant to give. So it's not necessarily that they're meant to give those measures and they're not. It's for us checking whether those national data sets contain them or not. So there's a bit of a difference there. So I don't think we can assume that they don't have that information, but they're not necessarily required to give us that information, and that might be where we need to do a bit of work. So it's a bit, at the moment it's a stock check, but it doesn't mean that they don't know those things.
Okay, can I just Chair, can I just come back? Not thank you. I mean, as always, Kath, that's a very helpful response. But I think, and we've been talking elsewhere about, as we move to an integrated care system locally through the Accountable Care Partnership, if we're not able to share the data that we have to tell a story, in particular about stressed populations in the city and those experiencing disadvantage, which means that the data has to be shared outside of the organisations, then we're really not going to be very effective at responding to their needs.
No,
Is
quite
that a
agree.
reasonable thing to say?
Yeah, I think that's true, and that's why we're doing this piece of work, so that we can assess where we're at now. It's very difficult to share person level data outside of the national processes for sensible reasons around protecting information. So I guess we have to look at this and decide, well, what are the really key areas that we want to concentrate on. We want to join that up with the council and look at the information they've got as well, because that's part of the jigsaw, and review all that together. So it's the beginnings of a piece of work, just to recognise what we do have. But there's obviously, like you say, there's a lot that we don't.
Thank you.
Thanks, Mark. Thanks, Kath. Chris, please.
Thanks, Kath. There's quite a lot of different sections in the report, isn't there, that it's really useful and interesting. Particularly caught by the 3.1 and all the COVID update, and to see it, laid out over the trends over time and salutary figures about the numbers of deaths. It was a query really about noting the COVID vaccinations in care homes, and my understanding is that it's mandatory for the care workers in care homes, not domiciliary ones, to be vaccinated by November. I appreciate that this isn't our lead, it's probably the local authority, but do we know what impact that might have, or if it's having an impact of greater uptake of the vaccine at this point? I don't know if that information is being sought, but it's coming up, isn't it?
So, Kath, are you able to answer that, or do you want me to deflect that to somebody who might be more involved in the vaccine programme? So, I
know the vaccines come up further on the agenda as well, so this might not be the right point for this. I just thought it was a really interesting summary on that report, and trying to think ahead really, because the care homes are such a vulnerable place, aren't they?
Mm-hmm. So I'll give a bit of kind of context nationally to what we're hearing, and then I'll pass over to Sandy, who might be able to give us a bit more local context. But there are concerns nationally that a number of people who work in care homes may not wish to take up that vaccination offer, and that might present a very sudden and very significant change in the workforce availability in the care sector. So it is something that we are keeping a very close eye on. And I know colleagues in Sheffield City Council really working hard with individual care homes to ensure that they're doing everything they can to encourage uptake. But Sandy will have some more detail on that, I hope, and I'm going to hand over to you.
Thank you, Chair. Yes, just to say, Chris, that we've added this into our risk register from our health and social care gold meetings that we're having at place at the moment due to the current pressures. Alexis Chappell, who's the Director of Adult Social Care, has very much flagged the risk that we're currently facing, and is putting together some numbers as to what the impact may have on that time. But we are looking at how we can come together as a health and social care system in order to mitigate that when it does happen. But it's very much on our radar, and trying to do what we can so that it doesn't have as big as an impact as what it could do, as Terry says.
Thanks for that, Sandy and Terry. It would be good to hear back, you know, what the outcome is of that, and, you know, if the mitigations has helped, you know, at a future meeting. Useful to check. Thank you.
Happy to.
Thanks, Chris. And it may be something that we could table as a question for Greg if he is available to join us at our November governing body. So we'll note that down as an action point for us to ask that question. Thank you. Any further questions or comments on this paper for Kath? No, thank you for bringing that for us again this month, Kath, and also thank you to you and your team for the constant evolution of this report as we ask for more details and things to be presented in different ways. I think you know, it's really responsive and is sort of giving us a lot richer information. Paper 13 now, item 13, which is paper H in the document pack, is the Patient Safety, Quality and Experience Report, and I will hand over please to Danny to present that.
So the paper provides an overview of the CCG's quality, patient safety and experience assurance oversight. There's a number of things that we capture in there, but I'm going to pick out a few points and then I'll probably open it up for questions. So just to give an update on a couple of providers in the city. So enhanced quality surveillance continues with Sheffield Teaching Hospitals and Sheffield Health and Social Care relative to their CQC inspections. One was on the teaching hospitals, maternity services, and for the Care Trust, it was they had their general inspection. So continued oversight continues with that, and we're working with the organisations to look at their CQC action plans and recovery. One thing to note is that the Care Trust's rating has, as of the 19th of this month, did increase from inadequate to requires improvement. And while it is an improvement and it's positive, they have recognised that they're still on a long journey of recovery in terms of moving back to good. So we continue to monitor those through our quality assurance meetings. Also to note that in terms of serious incidents, safeguarding and patient experience, we actively continue to monitor those for our quality assurance meetings with our providers and in association with our local authority colleagues. This is also to ensure that the processes are robust, and we're sort of reminding providers about lessons learned and how they disseminate them back through their organisations to support and reaffirm good practice. From a general practice point of view, we've continued with the work around the annual physical health checks for people with SMI, serious mental illness and learning disabilities. In the city, local improvement work includes regular contact with practices around individual completion rates. We've got healthcare assistants within the primary care mental health teams programme. We're doing raising awareness through training, and one of those is through Sheffield Mind. For the SMI, there's an outreach programme, and similarly in learning disabilities, there's an outreach programme through MenCat. And then what we've got in development is a training programme that will come online to target those individuals that are harder to reach, so potentially home visits. There's lots of other positive work ongoing, work that the PCDNs, the primary care development nurses are doing, and improve, links to the vaccination programmes. As Jackie's highlighted earlier, we are seeing some pressures, an increase in continuing healthcare, and some of that is a result of system pressures through secondary and care and through the care home sector. So I think I'll stop there, and then I'm happy to take questions, Chair.
Thank you, Danny. Any questions, please? Nope. Okay. So you presented quite a lot of information in that update. Are there any other particular themes, Danny, that you wish to draw out here?
I don't think at the moment. I think what just to highlight, I think from we're reviewing the current large providers in the city in terms of how we ensure quality, and from a quality perspective, and an improvement perspective, we're going to start undertaking some quality visits ourselves from a CCG perspective. With the providers, we're going to start with the Sheffield Health and Social Care Trust, and we're going to do that jointly with NHS England. So I think it's just something that we're going to ensure is a regular, ongoing to quarterly programme to so we can sort of do eyes-on visits to the providers and ensure that we're getting the right levels of care.
Okay, thanks, Danny. And I am assuming that those quality site visits will be fed back into our Quality Assurance Committee and fed back up to governing body as required.
Yeah, the first visits are planned hopefully for the first week in November. So yeah, we'll take that through a Quality Assurance Committee, and then it can be fed back. I don't know whether Judy's got any further escalations that you wanted to raise from Quality Assurance Committee, Judy.
My hand did go up. I was struggling to get my mouse working, unfortunately. Yeah, it was just to note in terms of the work that's been ongoing with the teams, and particularly with the Care Trust. We had the Director of Quality to the Quality Committee, didn't we, Danny, last month? And it was very refreshing and what's that word? Assuring
Yes.
the take of Sally, the quality director, on the improvement that has been made, but also recognising that there's still lots more to do. And in particular, it was good to hear about the ensuring that the way that they're working is working with us, but also with other partners, and particularly getting the voice of the patients and the carers. So that, I think it's important to note that openness and that transparency that we saw. And then also the only other thing I think I wanted to raise in this part of the meeting was some of the challenges that Yorkshire Ambulance Service, the paper's describing in terms of response times, etc. And we did ask at the Quality Committee if our representative from the CCG on the ambulance services meeting focused on quality could ask some specific questions and get assurance and bring that back to us around the experience, you know, that isn't impacting on outcomes and experience for our population in Sheffield. I think that was the only other things for this part of the meeting to raise.
Okay, thank you, Judy. Is there anything else anybody would like to ask at this stage?
If I can just add, Terry, sorry, about I was involved in a meeting with Alexis and Jan, Chief Exec from the Care Trust, just to say that we met with Sheffield Voices last week around, was last week or week before, around the concerns around FIRSL and obviously the CQC inspections. It was just to, what we did was reassure the group that we absolutely, in any redesign of service, we would ensure that we got the public voice and involve those individuals with lived experience. That was the assurance we gave them.
Thank you, Danny. A question coming up here from Chris, please.
Yeah, it was about the care homes again, and I mean, it's really pleasing to see that the visits in the care homes, particularly where there's been concerns, because I know that wasn't really achievable during COVID, but it's so important for quality. So I don't know if there's any information about reporting back from those yet, or if that's just, you know, a newer development.
So we are developing a joint quality assurance framework with the local authority. It's the local authority usually undertake the routine visits to the care homes, and where it has health or I suppose nursing involvement, then we will be involved, Chris. What we are doing though is working with them actively for care homes that are, as you say, potentially struggling or at risk. And then I'm also involved in the working group with Alexis around the risk in terms of the vaccination for the staff, and then the impact to the delivery of care. And the care home quality team is also feeding into that from the CCG. So I'm happy to give an update in the next patient safety and quality report.
Yeah, that'll be really helpful. Thanks.
Okay, thank you. So in the absence of any further questions, I'll move us on. So thank you, Danny, for presenting that paper. Now move us on to item 14, and that's paper I in the document pack. And it's a communication and engagement quarterly update. Now I'm noting Brian's absence this afternoon. Jackie has kindly agreed to step in to present this paper, but we probably just be cognizant that it's not Jackie's area of expertise. So Jackie's going to present some information to us, but what we propose at this meeting is we take the paper as read. And if there are any specific comments that we wish to feed back, we'll feed those back directly to the comms team. So over to you, Jackie.
Thank you, Terry. And yeah, I was just going to briefly say that this is a report covering the first quarter of the financial year, so April to June. The report obviously pulls out a significant emphasis on communication around the vaccine programme, and that's both in terms of the media coverage as well as our social media reach. And there's some useful statistics in the paper that outline some of that. The other point I just wanted to draw out is around our communication with staff, and CAF highlighted some of these issues in the report that she presented. So that is outlined in the paper. I think the other thing I wanted to note is that as the pace of work for transitioning to the new ICS picks up, and obviously that's subject to legislation, we will pay particular attention to the communications with our staff to ensure that they're properly informed and engaged with that change process, recognising that organisational change will be yet another area of anxiety for staff. So we have been giving some clear thought about our comms. You'll recognise it's important that those messages are consistent across all the organisations affected by change. So there will be a level of coordination between the CCGs and the ICS team around that comms as well. So I think they were just the main points that I've brought out from the report. As you say, Terry, we can take any other queries or comments back into the comms team.
Thank you, Jackie. Chris, can I check if your hand is up for a question or whether it's from the last item?
It's from the last item, but I have got a question, but let somebody else go first.
Well, while we've got you on the line, Chris, we'll let you go first, and then I'll bring Judy in second, please.
There was a couple of things really, just more I think the really innovative messaging, and was it a wrap, and also, you know, TV coverage for the vaccination, and that positive way in, and the intelligence about which groups and where we needed it, and also where we put easy access to vaccination centres. It's all about good communication and how, and you know, that evidence about behaviour change. So just wanted to note that, and also the work on, I suppose it relates to it really, the public involvement, experience and equality committee. Should let Mark speak for this one, but it's just seeing that the work that went on to be proactive, which we've had reports at the governing body, was it the last governing body? I can't remember. Those excellent feedback from the different groups. So just to recognise that work really, not to ask Jackie any tricky questions, but it's quite a body of different work and excellent response, and really thinking about who we need to reach, and one message doesn't fit all. So just to recognise the work that's been achieved on that. That's it. And you can, I'll try and take my own hand down.
Thanks, Chris. I'll take some points from Judy, please.
Yeah, thank you. Just three shortish and positive comments. Really good to see that the new contract for BSL interpreters is being done in a collaborative way, involving people who actually need and use these services. Healthwatch has been talking about this for a number of years, so it's great to see this is happening, and I hope we can draw lessons from using and working with people in future contracting, so that they're in the middle, patients are in the middle of that, not shoved to the corner. So that's really positive. The other one was about neurodevelopment. Healthwatch is doing, I think, with the CCG, a community event to draw in other communities to find out about their experience and how parents navigate the pathways. And I think, again, that's a positive bit of collaboration. And then thirdly, I know my Healthwatch colleague, Trish Edney, who you will know, was concerned about the Norfolk Park surgery. And I think, again, it's helpful to know that there's been a response to what patients were saying. And I think there will be a change of plan. I think that's a very good way to tackle a tricky situation. So I think some really positive developments there. And I wanted to just note those and thank you.
Thank you, Judy, for those comments, and we will make sure that they're passed back to the comms and engagement team. But I think a couple of the points you've made there do signal a way of doing things in a different way, and very much we'll in the various spaces that we're working in seek to ensure that we try and build that into future ways of working in a new integrated care system. So Leslie is taking close note there, and definitely we'll build that in. And I've seen Sandy on our call as well. And it's certainly principles that we're looking to really embed in our joint commissioning work with the local authority as we move forwards. So thank you. Any further points for this paper for us to feedback? Okay, thank you. Item 15 now, paper J in the note-in pack is the Governing Body Assurance Framework. And this one covers the period from April to July 21. And I'm handing over to Kath to present that paper for us.
Thank you, Terry. So I'm sure I don't need to remind you the importance of the GBAF and that it's the key process followed by the CCG to ensure that we're managing strategic risks that threaten us achieving our objectives. So as Terry said, this is for the period April to July. Ideally, we'd have taken this through audit committee before we brought it to governing body, but due to timings of meetings, that wasn't possible. So what we did was circulated the report a few weeks ago through audit committee to give them the chance to comment. The key points I wanted to note were an increased risk score for risk 3.2, which is about the risk of insufficient resilience in primary community care. And it was agreed that this would be increased due to the system pressures that Jackie mentioned them in the finance report. She was, one of the reports that she was presenting. I can't remember which one. I think it might have been the finance one. So it was felt that it was important to bring that in line with our other high level risks that had high scores. As well as going through audit committee, we also spent time at the senior management team discussing the report and picked up a few issues that will come through and be looked at as part of the Q2 review of the GBAF. Just to quickly highlight what those were, was looking at whether it was appropriate to reduce the risk score for risk 2.3 about effective communication with the public and involving patients. And based on the discussion we've just had, that certainly feels appropriate to do so. So we'll look at that as part of the Q2 review. And then the other point that was picked up was around the wording for risk 4.2, which is about the development of partnerships being risked by all the changes that are happening, particularly related to the ICS changes. It refers to delays in legislation in the risk at the moment, and given we've had quite a lot of information come through recently, we might want to look to reword that risk. So we'll pick that up as part of Q2 as well. That was all I wanted to highlight, so happy to take any questions or comments.
Thank you. So any questions or comments? Lee, please.
Yes, thank you. Thanks, Kath, for this paper. You would expect me to say this, wouldn't it, that we cannot walk past that increased risk around the resilience in primary care. It is a huge issue, and I feel a lot of people are trying to make the message heard, but not always certain that it's getting a response. And it's not just that people need to know the pressures, but I think we all need to understand the consequences of those pressures. And I'm also thinking about the previous paper around quality, and within that there was mention about access for patients and how often patient satisfaction and people's experience of care is often worse in the more deprived areas. There are a few notable exceptions, but you know, the impact of increased pressures within primary care will undoubtedly increase health inequalities because of all the reasons that we know, and I think as well we understand that it will have a huge impact on the rest of the system for all the reasons that we've talked about lots of times. You know, you only have to increase your referrals by a small amount to have a massive impact on the wider system, which is already creaking as well. And so it isn't really a cry for, oh, we need more help in general practice. It's this constant, I think it's my now constant refrain is, how as a system are we really going to tackle this, and do we really understand what the issues are and how they can be addressed? Because actually there are a few things which can be done quite quickly by the system at no extra cost, which we have talked about outside of this meeting. But I suppose it's just to note and make sure that as a governing body we are aware that this is a massive issue. And I mean, the other locality managers here will, I'm sure, echo what they've heard from their practices, that people are very worried. They've never been this busy, and we've just come to the end of summer and we're looking at winter and feeling very worried. So just to make a note of that, really.
Thank you, Lee. Anthea, please.
Thank you, Kath and team, for putting this together. So one of the challenges that I raised when we reviewed this over the summer was the number of critical risks that we now see. And the definition of critical is actually quite tight, and I don't want to guess and get that wrong in a public meeting. But I believe it involves possible loss of life. I mean, and that's the situation that we're looking at now. And then you couple that, we've got 3 risks that are critical, all of them really looking at partner organisations that were worried about the system. And yet earlier in governing body, we saw a paper that said we're fully prepared for any emergency. Now, I understand that an emergency is different from risk management, and one is sort of more of an accumulation of things that have happened rather than an aeroplane crashing over Sheffield. But I do wonder if we're worried about partners' delivery, and we've just heard Lee say primary care is critical, whether we need to revisit how we think about emergency preparedness and how we think about risk assessment as well, and bring those two together more.
Thank you, Anthea. I think Lee would like to come back on that one, so back over to you, Lee.
I would, thank you, because I was thinking just about this point actually earlier on in the meeting when we were looking at the 52-week waits, and actually understanding that that's a consequence of an emergency that happened. But the consequence of the way that emergency was managed is going to be having an impact for a very long time. And I suppose it's just sort of backing up what you're saying really, Anthea, is that maybe the way that we think about managing an emergency shouldn't be just about, well, how will we get through that emergency, but really understanding and what will be the long-term consequences going forward. And actually, because I think we could do a lot of reflection now looking, I mean, it's easy, isn't it, in retrospect, to look back at how we did manage the COVID. And we really managed the acute COVID illness very, very well, but at a huge cost to other parts of the service. And I think if we were all to look at that again, we may well have done something differently. We could still have done what we did for COVID, but managed other things differently. And so I think it's really, really pertinent what you're saying, Anthea, is we've got to understand not just how we manage emergencies, but actually what the long-term impact is going to be. And that's I agree with you. I think the state of play at the moment for a lot of providers is coming close to an emergency, certainly coming close to crisis. And so when we're thinking about, well, how are we going to manage it, it has got to be, you know, to manage the acute situation, but also how we can build something going forward that's going to be sustainable and better.
Yes, and I don't think a year ago we had 3 critical risks. So obviously a lot of that is learning and presentation of what we've done in the past year, and we've got the vaccine now, which is wonderful. But I just think what should we be thinking about now so that we don't have 7 risks in 12 months time, critical risks in 12 months time as well. I think we need to ask ourselves that.
Thank you, Anthea. I'm bringing in Mia, please.
Thank you. Yeah, I mean, I totally agree with Lee and what Anthea's been saying. For me, part of the reason, certainly in primary care, with which I'm most cognizant, is, again, we're back to the dots are there, they're just not being joined up. Now, to be fair to the inverted commas system, there has been huge amount of resource put in during COVID. But as always, the GP practice is seen as the kind of bucket into which everything falls. So more and more, whichever organization is contacted is contact your GP. I mean, you know, specialists kind of 119, etc., people who are set up to deal purely with COVID, we end up taking those calls. And, you know, people ask what can be done. I mean, I don't think, Lee, that is long term. I think it's very short term. And to be honest with you, I think we're looking at, in the next 3 months, you know, certainly from my personal experience, working in a practice where half of my staff are off and the clinical staff are completely on burnout. They should have had the summer to recuperate, traditionally a time when people can get away and kind of refresh and come back for the winter. We're trying to prepare for what we assume is going to be a very, very difficult winter. And again, as great a job as the communication and engagement team does, we saw the paper earlier on, I don't know how we can get the message more and more across to the patients who use the service of where else they can go. Part of the problem is that we are so overwhelmed with queries, and I wouldn't say minor because everything is important to somebody who asks a question, but where people other than GPs could deal with some of the problems and leave us to actually kind of deal with the issues that may end up in A&E or secondary care. If you look at any typical GP list of 100 people, you can knock 40 or 50 of those off. They could have gone somewhere else. We've kind of played with the idea of directing people to the right service, the right time, etc. But unfortunately, the bottom line, again, always tends to be the GP. So I think for me, the issue is focusing on education and trying to direct, again, people to the appropriate services.
Thank you, Amir. Could I bring in Judy, please?
Thanks. We did have a discussion along similar lines about, well, workforce generally, and then also specifically workforce and the issues within primary care. And one of the things that we've asked as part of the quality committee is that via the quality group meetings with each of our providers, and we're going to take this discussion also to the primary care commissioning committee, we're going to be asking what is happening in terms of the well-being and the humility and the humanity of the staff, recognising the impacts of the pandemic and the ways of work that staff have been experiencing on the front line. And we've asked for that for 2 reasons. One is to seek some assurance that each provider is being aware of the workforce needs and have got plans in place around resilience, and we recognise that the CCG, in its kind of helicopter role, has an opportunity to share if there are some things in place that are working well and that can be, adopted and spread. And then the other thing that we talked about is specifically in terms of primary care, and I'm just kind of in my own head now linking the fact that we've talked about the winter planning, which no doubt is already underway. And is there something, taking Lee's point about the fact this is system thinking, do we need to, if we're not already, plan something whereby we do that loop back and that thinking so that we can plan slightly differently for winter? I don't know.
Thanks, Judy. And Jackie, please.
Yeah, sorry, I was just reflecting on Amphi's comments and the kind of risk profile that we have. And there's two possible explanations for that. Either we've become more risk averse or the risk profile has really increased. My take on it is that actually, if anything, our risk appetite has increased. We're more prepared to tolerate risk, not we're more risk averse. So I think the kind of risk environment we're working in has significantly increased. Obviously, a risk management system is not just about identification of risk, but it's looking at mitigations and actions that can be put in place. And I think they are increasingly difficult to identify actions that will mitigate or reduce the risks that we're facing. And I think that is a level of kind of challenge that we're all trying to balance out. So I think the primary care risk that Mia has just articulated is a very pertinent example of that. And I think it's probably really key as we go forward that we're just looking at every opportunity to manage some of those. And I think probably the solutions aren't one big bang thing that will solve some of these things, but whether there are a number of actions that we need to take to manage some of these. So I suppose I would just encourage governing body members just to reflect on the risks that we've got, and if they have got ideas of what we haven't identified, it would be useful to play those in. But I think just the whole environment and given the rapid change as we transition into a new organisation, the risks inevitably will increase, and it's beholden on all of us to think about how we can support each other in terms of managing that.
Thank you, Jackie. I'm just going to build on your point and your question, and this is probably a technical question about the GBAF, where I know that having discussed this with other people, there's a question here. Is we recognise that we've got a critical risk in 3 areas, and in particularly we're sort of building on the capacity problems we're recognising there, and then the resilience in primary and community care. I know in the GBAF that we don't have any gaps in assurance and we don't have any gaps in control, and kind of just hearing some of the discussions, if we don't have appropriate mitigations, can we be assured that there aren't any gaps there? So that's my first technical question, and that's probably a question to Kath and Jackie about how that's presented. But I do think there's a really important point here, is we recognise the seriousness of these things that are here on our assurance framework. And I think obviously not for today's meeting, but at a later date, it would be helpful to hear kind of what mitigations we are planning or putting in place, so that we can have assurance as a governing body that things are heading in the right direction. And just to really build on what Lee has said, I don't think that the mitigations are things that we are going to be able to solve on our own as a CCG. And this very much requires us to work in a more system-focused way, both locally here in Sheffield, and indeed for some of these things across SYB. So that there'll be a real need for us to dock in with partners in the ACP. And I'm aware a primary care paper has gone to the DG group this week, but in addition to begin to dock in and work with our primary care colleagues across South Yorkshire and within the ICS. So I will take two final points then. So Marion, please.
Thank you. We've talked a lot about resources and we've talked about resilience, and certainly in the patient survey, the big criticism of Sheffield was access. People feel that they can't get into the system. So they get into the system, which to them is the GP. And then what do we do? Because we're already saturated. And this is a point that Amir's made. Everybody thinks they need to see a GP. So there's two things that's playing to our favour. One's Primary Care Sheffield, which is a fabulous resource. And I think without that, Sheffield GPs would have just burned out, end of. Because they've got the hot hub and the cold hub system, which can be flexed. So if the demand in the city is rising, they're monitoring that and they put on additional sessions, cold hubs, and if it's the COVID side of it as well, the hot hubs can go up. And there are doctors out there who are willing to work those sessions. So that's a safety valve. The other thing is the primary care networks, and there's a funding stream now that we haven't had for very long, bringing additional professionals into the medical field. And I'm thinking here of pharmacists and nurse practitioners and physician's assistants who are able to work alongside GPs, and that makes the GP more effective. So we can spread ourselves a bit more thinly without compromising patient safety. We talked a lot about the system and the continuum in which we work, and I had an occasion this week, and this is not August bank holiday, the week before, in the afternoon of an August afternoon, the ambulances were on red alert. Well, that's never ever happened to my knowledge in August ever. So we're stretched, but the ambulance service is just as stretched, and goodness help us when we get to November was my immediate thought on that one. So we've got to learn the lessons that we have come through this year, the experiences that we've had, and we've got to forward plan, and we've just got to future-proof ourselves to keep the system working. Thank you.
Thank you, Marion. Lee, please. You may have the last word here.
Oh my goodness, thank you. I'll be very brief because I know I've already spoken, but I think we've talked a lot through the year, haven't we, across the country, of how COVID has actually accelerated stuff that might have happened anyway and uncovered stuff that was going on anyway. And I just wonder whether actually what we're all talking about is how COVID has accelerated as the realization that maybe the NHS as it is set up is actually not fit for purpose. And it was designed in a certain way, but actually for the 21st century, we need a very, very different sort of system. So we are going to have to get through the winter. And I think, utilising the hot and cold hubs and all the ancillary stuff, everything else, that's fine. But going back to what Anthony was saying as well, is thinking long term. I think there are no more efficiencies to be made within the NHS. It is cut back to the bone as it is. And the answer isn't more consultancy. It probably isn't even lots more GPs or lots more nurse practitioners. It is changing the way we function and changing the way we view healthcare and getting in the community sector and the voluntary sector and having resilient communities and actually demedicalising a lot of the stuff that's going on and empowering and activating people to know how to look after their health and to build up resilient communities and to look back at the Sure Starts centres and all that stuff. And that's why it's really absolutely front and centre in what we should be thinking about as a system, that we need to look at how health is actually everybody's job. And having it just as a concern for the health professionals isn't the answer. And we've reached the point as a society where actually we've no more capacity, and to carry on doing more of what we're doing isn't the answer. We are going to have to look at it differently. So I said I was going to be brief. I wasn't so brief, but I will stop now.
Yeah, I think it's a really important point. And if I can summarize that, Lee, it is essentially don't keep doing what we've always done. It's now time to work as a system and to do things differently. And I do hope we have some opportunities for that in the future. Okay, I think this paper starting to animate everybody. So hands going back up there. So points from Judy and Marion, and then hopefully we can bring that to. Oh, okay. So Judy, you will get the final word.
Yeah. Well, I just wanted to underline what Lee said. I think that's absolutely right. Unfortunately, the voluntary community sector and the engagement sector and all that are the ones who have least resource and are in a really, you're in a difficult position, but boy, we are too. And I think the system, I mean, the stuff I was talking about earlier, that, you know, this sort of stuff, that engagement is on the side, it's not central. And I really would make that plea to putting people at the centre means changing the way the system works. And I don't think we've come to grips with that at the scale it needs. But I agree it's a cultural change that we really need to put in place.
Thank you, Judy. Okay. Kath, I think you've had lots of feedback and lots of discussion of the GBAF, and that's quite unusual for one of our governing body meetings. So thank you everybody for participating in that discussion. I think one of the key takeaway points is we probably want to do a bit of a deeper dive into those risks, and perhaps we will schedule that for a later governing body meeting, particularly as we head towards winter. And those of us that are involved in collaborative working arrangements with the local authority through our joint committee, through our ACP space and in our ICS space, will certainly be playing some of the story we've heard this afternoon, and many of those comments, playing those out in the different forums through which we interact. Okay, I'll take us now on to part 4 of the agenda, which is our accountable officer update. So I'm going to hand over to you, Leslie.
Thank you, Chair. I think we've referenced our journey to an integrated care system in every one of our discussions this afternoon, and we've probably covered much of my update already. The other thing we've reminded ourselves of during the discussion is that this is all subject to legislation. So I think the first thing for me to point out is that subject to that legislation being passed, and the expectation is that would be around February 2022, we would see the establishment of an integrated care board, a statutory board, and an integrated care partnership, and the partnership being a committee of partners. So just as we get used to the acronym ICS, in the future, we'll have ICBs for integrated care boards and ICPs for integrated care partnerships. Again, much of the preparatory work around this is happening subject to legislation. So the appointments process, the appointment of designate roles is beginning. We've already updated on the appointment of the chair, independent chair to the partnership, who would become the designate chair of what would be the South Yorkshire Integrated Care Board, and that being Pierce Butler. And then during the month of September, the recruitment begins for the chief executive of the South Yorkshire Integrated Care Board. In the last few weeks, we've seen the publication of a range of guidance that I just wanted to bring to governing body members' attention. So we've seen interim guidance on what will be the functions and the governance of the Integrated Care Board. We've also seen a draft model constitution published. This is important for us because within the legislation, within the bill, CCGs will be both asked to propose and to consult on the constitution for the Integrated Care Board. And we picked up earlier that our means of doing that would be through the joint committee, so that we would do it as one across South Yorkshire and Bassetlaw. Equally, guidance has been published on the statutory CCG functions, which will be conferred on the Integrated Care Board. Importantly for us, an HR framework for the development of that board, which, although relevant to all partners, has particular significance to those partners such as CCGs that are impacted by the change, and particularly for groups of staff such as governing bodies where that employment commitment doesn't hold. So we do have the publication of HR framework. We also have the publication of guidance on the development of an ICS people function, relevant to much of our discussion today, because that's about one NHS, one workforce, working as one system. So again, reflects some of the discussion that we've had today, and indeed one of the items that we've carried in our matters arising for some time, which is understanding the staffing challenges and the use of agency staff across our system. So guidance published around the establishment of the people function of an ICS. We've got publication of readiness to operate statements for integrated care boards, and those will be built on the other side of the coin, which is the transfer side from CCG, so the due diligence piece. So we've now got guidance on the due diligence, and again, that's something that we'll take forward through that change and transition board and the joint committee. And I think really just the last thing for me to add is the development of locally of our People's Hub, where everyone can see latest updates either on appointments or frequently asked questions and answers, or all of the guidance or updates on webinars, etc., around this transition towards being an ICB, and all of the guidance held on the future NHS collaboration platform. So I think I will stop there and happy to take any questions on any of that.
Thank you, Leslie. So I will open up to questions, but just before we take any specific questions, just to note that we do have an in-depth discussion coming up later in another meeting, specifically to go into some of the finer details of the HR framework. So just note that. But does anybody have anything they want to ask? So Jackie, please.
It's not a question, it's just a comment, just to note that Remuneration Committee met before this meeting, and one of the things we noted is obviously CCGs have legal responsibilities in terms of consulting with our staff as part of this transfer. So we had a discussion at Remuneration Committee just updating members on the proposed arrangements, specifically around the HR framework and the arrangements in place across South Yorkshire and Bassetlaw, and hopefully members will confirm that they gained assurance from that update. So I just really wanted to note that that level of oversight has happened and will continue to happen.
Thank you, Jackie. Okay, Leslie, you've got off lightly there with the questions, so thank you for bringing those updates to our attention. And as Leslie has pointed out, those documents are available on the future NHS collaboration portal, which all governing body members can sign up to and log into. And for members of the public, I believe almost all of them, in fact, all of those documents should be available on the NHS England website. If you go onto the publication section, you'll be able to find relevant guidance and interim guidance that has been published and shared with CCGs and integrated care systems. Okay, I will move us on then to reports circulated in advance for noting. So does anybody have any comments that they wish to make on any of those papers? So Chris, please.
Hello, I just wanted to draw attention and make some comment about the annual assessment and the letter from NHS England. Really, there is really excellent feedback about some of the key issues, quite a few that we've discussed in this meeting, in actual fact. And some of the key areas that it covers about improving the quality of the service, which includes effective use of resources. The issue we talked about getting back to, trying to get back to normal and making a lot of progress on that from pre-COVID. They also point out the overall systems and processes and system-wide, so ICS-wide, that Sheffield has led and made a difference with, and the inequalities, particularly during COVID, and how we manage that. I think the other section that's really key, that I know we've put a lot of work in, is overall reduction of inequalities and focus there on the engagement with deprived communities and particular groups like the homeless and the travelling community. So some really specific feedback about the achievements that we've had. Also, I think of note is the changes in culture from where we were 2 years ago, the support for staff well-being over COVID, and also the engagement of staff. So there's a real influence of staff on strategy and key ways of working. And last but not least is the leadership, and particularly Terry and Leslie are complimented on how they've led this process for the whole system. And also it says, the letter says, thank you to the whole team's dedication and support over this time. It is a pity that there isn't, there's usually a kind of graded category assessment, and I think that would have got an excellent, but it does summarise some of the things that we've touched on that we want to do more about at this meeting, but I think needs some noting, and thanks to the people, everyone concerned who's contributed to that progress.
Thank you, Chris, for highlighting that. So the annual assessment, obviously it is here in the noting pack. It's also on our website. I agree. It's a shame that there wasn't, kind of star rating. But I think the process having changed this year and last year as we went into COVID from the usual kind of graded system has actually allowed us to receive a quite detailed narrative of some of those things. And whilst it's different, I recognise some of those key things that have been highlighted there, and in particular recognising the contribution of all of our people in making that happen. And Leslie and I, when we had that review process, were particularly keen to show some highlights of a video from one of our governing bodies where our staff and our team came to present our annual report, and that formed the basis of our annual assessment. So really, it wasn't Leslie and I being assessed on behalf of the organisation. It was a real broad range of people, and we are very proud of everything everybody's doing. So Leslie, is there anything you want to add?
No, I think you've captured it just there at the end. I think it was thank you to everyone, and just recognising that yes, we did use the video from governing body when all of the staff came to talk about the annual report. And I think that helped build the narrative for us. So that was great, and thank you to everyone involved.
Thank you. And just to note as well, all of those people who did come down to governing body to speak with us, Leslie and I have written out to them all just to thank them for their contributions on behalf of governing body. Okay, any other business that anybody wishes to raise? Nope. Okay. Just one final item that I missed off the agenda at the beginning is just to confirm that we've not had any questions this month from members of the public, but just to remind any members of the public who will be viewing this online, if you visit our website, you will find all of the contact details and mechanisms by which you can make contact with us to ask governing body a question. So thank you everybody for today's meeting. I think we've had some quite lively discussion and debate, and as always with the public sessions, if possible, I'd just like to hear a few key summary points and reflections from governing body that we'll go and share with our partner organisations, with our practices and with our individual teams. So does anybody want to start? So Anthea, please.
I feel that we are slightly shifting, that we are thinking about the CCG and we are now thinking more about the partnership. And we've already done that, but I think we are getting much more into that regime and how I would hope that the ACP, at least partnership board, may function in the future.
Yeah, thank you, Anthea. Does anybody else want to add any reflections? So I think we've done a bit of reflecting as we go along. I just want to pick up on Judy Robinson's and Lee's point there about, you know, we've got to think much more system wide and working as part of that system. But in doing so, we need to think about how we do things differently in the future. I think that's one of the key reflections that I've pulled out from today's session. And, you know, kind of recognizing that that might be the way we need to respond to many of the pressures that we've heard about today. So any further points? Okay, right, I will bring the meeting to a close. So our next governing body in public will take place on the 4th of November at 2 p.m. Details of the meeting will be confirmed on the CCG's website.